Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Today's presenter is Dr. Amir Dastgah. Dr. Dastgah is a podiatrist.
Good evening, everybody. My name is Dr. Dastgah. Going to talk about sick feet tonight. At the wound care center, we treat diabetic ulcers, venous ulcers, post-surgical wounds, pressure ulcers, ischemic ulcers, which means they don't have enough circulation, traumatic wounds, burns, and frostbite, and many other wounds. When you get to the wound care center with whichever wound that we talked about, initially the most important thing is to evaluate the vascular status of the patient, vascular evaluation, and also get some laboratory testing, find out what organism is growing on the wound, nutritional management and nutritional status by getting some blood work. And if the patient has pain, we manage the pain with pain medication, and if there is any problem with radiculopathy or any major pain management issues, we refer to Washington Township Pain Management Group for further evaluation. Diabetic education and radiology, if they need any x-rays, MRI, or bone scan, that's the nuclear medicine. Wound debridement is done if the wounds they don't look good, they're not healthy, and I'll show you some wounds that need wound debridement. This is the hyperbaric oxygen therapy. I think some of you guys have seen Michael Jackson when he was alive. He had one of these in his house, and I'll tell you more about it. Just remember this picture. To help in your healing, you may be referred to this hyperbaric oxygen chamber, and just remember, not everybody is qualified to have this, and not everyone needs it. But it is a simple but effective treatment in which you breathe pure oxygen inside a pressurized chamber. It has basically glass sides, and then there's a TV where the patient actually sits inside the chamber and could watch TV, and you're breathing. And it basically increases your body's own natural wound healing by increasing the oxygen in your bloodstream. I'm going to talk about diabetes, and it is a big problem in the world. In China, as we know, there's 1.4 billion people in China, and India is about 1.3. And just recently, India became the second largest country that has diabetes, and China surpassed it. And 62 million of Indians are diabetic, and about 100 million Chinese, they do have diabetes. That's a big number. And if you see the population in Fremont and the Bay Area, we have a diverse group, a melting pot, but there's a lot of Chinese and diabetes, and when they come to this country, we need to take care of them. Here in America, we have 29.1 million patients with diabetes, 8.1 million maybe undiagnosed or unaware that they have diabetes. About 1.4 million new cases of diabetes are diagnosed in the United States every year, and more than 1 in 10 adults who are 20 years or older have diabetes. That's a big number. As far as podiatry, it's my profession. Podiatry is a branch of medicine devoted in treatment and diagnosis and surgical treatment of foot and ankle and lower extremity. Let's talk about actually wounds and diabetes. Pathophysiology. Usually these patients have high blood sugar and it's not controlled, right? The reason the wounds are not healing because they're immunocompromised, right? Just like patient with rheumatoid arthritis, psoriatic arthritis, HIV, diabetics are immunocompromised too. They can't heal. Why? Because the blood sugar is high, and the white blood cells and cells that are there to help us get rid of the infection, they're kind of drunk because of the high blood sugar, right? They have neuropathy. What is neuropathy? They don't feel their feet, right? That's sensory neuropathy. Initially when you have diabetes, you might not have neuropathy, the sensory neuropathy, but as diabetes progresses, within 15 years, it is known that most of the patients do get some sort of sensory neuropathy, where, if you have a pebble in your shoe or a foreign object in there, they don't feel it, right? And that's when the problem starts to happen, right? You don't feel it, and your eyes they're not that good, And you come home and all of a sudden you just look at your white socks. If you're lucky and you're wearing a white socks, that you got blood there, right? Or it smells. That's the first time you recognize you have an open wound. And by that time, it might be too late, right? It might be too late. If they wait and they don't go to the doctor, don't get the right antibiotic, right care, they may end up with amputations. It happens a lot. And poor circulation. That's the other thing that the diabetes get, right? A lot of diabetic patients from knee down, they have poor circulation. Micro and macro, big vessels and small vessels. Mechanical stress, right? As we were talking about motor neuropathy and autonomic neuropathy, it causes a lot of problem. Motor neuropathy causes you to have hammer toe deformity, right? All of a sudden the patient has diabetes and they say, doctor, I had perfect feet, nice feet, like a model. And all of a sudden now I have like hammer toes or mallet toes, bunion deformity. My foot, there was a bone protruding out of my bottom of my foot. I don't know why. My doctor can explain to me. I went to my primary care doctor. That's motor neuropathy. That's causing you to have these contractures, right? Initially, it's flexible. It reduces when you stand up, but as it progresses, it becomes semi-rigid, and then later on rigid. It doesn't reduce. You stand up, your toes are sitting there, and then that's when you start having corns and calluses on top of your hammer toe. And then also, as I said, patient and provider neglect. The doctor doesn't know, and the patient also neglects it. We talked about 29 million of Americans having diabetes. 60% of all lower extremity amputations in the US occur in the diabetic patient. That's a big population. So controlling them with proper managed care would be an ideal thing. The more proximal amputation level, the greater expenditure in energy. What does that mean? So if you have a toe amputation versus a below the knee amputation or above the knee, that matters to your body. When you have more proximal, like a below the knee or above the knee amputation, you require more energy to move around, right? All of a sudden you lost half of your limb. And even though you have a prosthetic, but it does require more energy to walk around. Most of the time, within 5 years, when you have had one amputation, you will end up with another amputation, very common. And a lot of diabetics have that. All foot and ankle surgeons will inevitably face the need to amputate part or all of the foot at one point in some of the diabetic patients. Cellulitis, skin infection, superficial skin infection, redness, the foot is swollen, to go to the doctor. The diabetics are 9 times more frequent in diabetes than non-diabetic. Osteomyelitis is a bone infection of the foot, 12 times more frequent in diabetics than non-diabetic. Foot ulceration and infection are the most common reason for a diabetic to be admitted to the hospital. So that's why Medicare, for example, has this program where they dispense diabetic shoes and diabetic insoles to a lot of diabetic patients, all the diabetics that need it. And all you need is a prescription from your podiatrist. You take it to Hallows Pharmacy or Hangers, and they'll dispense you a diabetic shoes with 3 insoles every year, because they know if they prevent ulceration, they prevent hospitalization. Very expensive, right? The sensory neuropathy that we were talking about, you could have diabetes and have sensory neuropathy, but you could also be, drinking most of your life and you get alcoholic neuropathy, right? There's other ways you could have neuropathy, idiopathic, where the doctors don't know. Or you could have like some lower back problem and you had surgery and all of a sudden one part of the nerve gets damaged. But whatever the case is, if you have sensory neuropathy, you don't feel your feet to some point. Some people might just not feel the toes. Some people maybe up to the knee. They don't feel anything. You touch them and they don't feel the vibration at all. Some of them about 20 seconds and then they don't feel the vibration. And it could be at the toes, like the big toe joint, or it could be even up to the knee. They don't feel it. Those patients, if they have pressure in their shoes or abrasion in their shoes or tear or breaks in the skin, they're prone to get big ulceration. And it's hard to tell those patients, listen, be careful, don't do too much, because they don't feel anything. If you don't feel pain, right, they could walk and they hurt themselves more. Sometimes some of these amputations are done in the office in some rural areas because you don't need to take the patient to the hospital. You don't need to numb their feet because they don't feel anything. You don't need to give them any local anesthetic. 25 to 50% of diabetic foot infection leads to minor amputation. 10 to 40% require major amputation. That's the below the knee amputation we were talking about, above the knee amputation. 10 to 30% of patients with diabetic foot ulcers will go to amputation. I talked about motor neuropathy and hammer toe deformity. I'll show you some pictures where the foot collapses because of neuropathy. Sometimes the patient ends up in a hospital, even emergency medicine doctors, they don't know. They think you have a cellulitis, skin infection. They'll give you antibiotic, but they don't know there's something called Charcot arthropathy where your joints disarticulate, and you start to walk on the bones, you start having ulceration. Some of it is because of the predisposed condition, the hammer toes, bunion, or tightness in the calf muscle, where you are unable to dorsiflex your foot, right? That creates more pressure on the ball of your foot. That creates callus formation, and if you don't trim the calluses, you develop ulcerations, right? You go to Disneyland and you walk with your grandkids, those calluses were never trimmed, you walk on it, you get a blister, you're like, oh, I'll just wait till 3 days and I'll go see my podiatrist. By then, that blister may turn into an infection, right? And goes up and could cause a limb loss. This is a hammer toe, right? If you look at it on the second toe right there, this person developed a corn, right? Initially, when you have a flexible hammer toe, you won't have this problem because once you stand on your feet, the toe deformity or hammer toe deformity doesn't appear. It's only when you're sitting when you could see that hammer toe. But in this patient, it is a late stage. When you look at here, they have a bunion deformity, a hallux valgus, the toe is butting the second digit, the big toe. And if you look, every toe from here on, you don't see the toenails. This is a mallet toe. The deformity is not at the proximal interphalangeal joint, but is at the distal interphalangeal joint. And they develop thick nails, toenail fungus, and a callus right around here, maybe a corn on top. That's a bunion. Initially, some people have bunions as early as like 14, 13 years of age, but a lot of times is older patients. They wore high-heeled shoes or wore dress shoes, and then at the 50s, 60s, you develop this big bump right there, and then it ulcerates there and gets into the joint. The infection gets into the joint. You would end up with a bone infection and loss of half of your foot. From here, there, a talus bunion, right? Same thing. It's just like a bunion on the opposite side. We call it also a buniette, small bunion. A person with flat foot deformity, not only they have knee problems, they have also foot problem. If you look at it, the heel is in the valgus position, it's tilted out. They develop a lot of pressure points right on the medial side of the foot, from the toe all the way to the heel. So they're prone to getting skin lesions, abrasions, and then later on maybe ulceration and bone infection. This is the Charcot we were talking about, right? Diabetic patient get it, but Charcot was a doctor in France who basically found out about Charcot. But back in old days, diabetic patients would die in 1838 because a lot of diabetic patients didn't have the medicine to survive, Type 1 diabetic would never survive, but type 2 maybe, 5, 10 years. But now we have medications that allows us to, keep the diabetic patients alive. During Charcot time, when he learned about Charcot, patient with syphilis stage 3, tabes dorsalis, they had this because they would get it, or leprosy. But now the diabetic patient get it, and usually you go into the hospital, you got a red skin, hot skin, and you go to the doctor, emergency room, the doctor says, oh, you have cellulitis, I'll give you some antibiotics. But you know what, this antibiotic will not help you. What you need to do, offload, basically be in a cast, can walker, and prevent any excess pressure on the foot, right? If you basically use crutches, you heal fast, right? Or get on a knee scooter. The more pressure you put on here, the worse this gets. And if you don't diagnose this patient, I'll show you some cases, what happens. This is a Charcot classification. A lot of Charcot deformity happens at the ulceration, and the collapse happens at the metatarsophalangeal joint. Some of it happens at the Lisfranc joint, the tarsometatarsal. Some of it at navicular cuneiform, talonavicular joint, some ankle joint, or the heel, okay? This is a patient with Charcot foot, ulceration at the big toe joint, first metatarsophalangeal joint. You see the toe is deformed, puts pressure point, and this patient has a collapsed joint here. If you look at it here, let's assume this was the same patient from last picture. And if you look at the joint, half of the joint is basically eaten away. Sometimes to a person that is not a professional, they think maybe you got an infection or maybe you injure your foot, but that's Charcot. The joint disarticulates and is eaten away. All that happens is because autonomic neuropathy increases the blood flow, right? And as the blood flow increases, the joint disarticulates. It's like a rainy day, and you're a river, and you see the rocks and the sand falling and running into the river. That's basically it. The bones disarticulate. This is the other picture. So you could have it at the hind foot, you see? And if you look at it, the foot is a rock bottom foot. It doesn't have that arch. It's really flat now, right? And I'll show you a picture right here, you see? The reason the person develops this ulcer right here is because the joints collapse. Half of the foot is collapsed right in the midfoot, and that's Charcot. It could be infected if bacteria gets into the bone. You could have also bone infection plus Charcot, but sometimes, or most of the time, it's just Charcot. Same here. Ulceration, nice beefy tissue, but the person has bony prominences right there, And as a foot and ankle surgeon, you go and resect that piece of bone that's digging into the flesh, and that helps usually. Conservative care is wearing these boots rest of your life if you don't want to have surgery. It's called a crow walker. And this is a Charcot patient with an ankle Charcot, and they get in wound care, right? A big ulcer, you manage the wound, you heal the wound. This is a wound vac where it sucks all the drainage so it doesn't stay on the wound, it goes into a canister. This is later on when you need Charcot reconstruction. You reconstruct the foot. This is a frame, external fixator. You don't need to open skins or anything. You just relocate the joints by this frame. This is another frame and a Charcot patient. Now, if you have high arches, you develop pressure points right here. It's called a tripod foot. So you got pressure right here and the ball of your foot, all this area. The autonomic neuropathy causes dryness in the skin. The Charcot is one reason. It's sensory neuropathy when you don't feel your feet, and also increase in blood flow where the joints disarticulate because of it. And also autonomic neuropathy causes heart dysfunction, GI abnormalities, right? They have to go 10 times to the bathroom, because it has affected. At the wound care center, we also see venous ulceration, right? The most common area right here. Least common is right there and above the ankle region. And that's because of a faulty valve, and that could be taken care of by the vascular surgeons. So when you see somebody, a family member with a varicose vein, have them come in, be tested, because, it's maybe not as bad as this person, but it could be taken care of by just ablation of a vessel, and they don't have to go to the wound care center, for years in order to heal this wound, because sometimes you heal the wound and they get better, then they stop wearing the compression stockings, and they'll develop another one. But in early stages, you could help that patient. If you look at hyperpigmentation, all the red blood cell leaked out into the skins, and you see the hemosiderin gets into the skin, and your skin gets tattooed with red blood cell. Also, we see surgical wound. This patient might have had poor circulation, right? The doctor never checked the circulation and had surgery, or maybe the patient had their wound, the surgical dressing wet, right? Got wet in a shower, or got, step on something, dirty water or something in a rainy day, and you get a bacteria there, and now you have an infection. As you see, this is all devitalized tissue that needs to be removed. And that's what we do at the wound care center. This is another surgical wound with some devitalized yellowish tissue that needs to be debrided. The other reason patients get wounds are pressure ulcers, right? Mom and dad maybe are at home, they're sleeping most of the day in a bed, right? They got pressure ulcers, right? Initially you get this superficial ulceration, redness, and then if you don't take care of them, that's what happens, right? It opens up, you get infected, it initially is in the soft tissue, but then it could get into the bone. If you know somebody that's sitting in a wheelchair or in a bed, make sure they got an air mattress and somebody who turns them around, right? I see a lot of times, even in patients in nursing homes, they come into the podiatry office and you look at the wheelchair and there's a piece of metal sticking into their skin and they don't have their shoes on. That causes decubitus pressure ulcers right there. And if they're sitting on the wheelchair and basically don't have a lot of fat, you get ulceration there or there, right? Ischemic ulcer, all it means it doesn't get enough oxygen. The tissue needs, in order to heal wounds, you need oxygen. So if you don't have enough oxygen going to the lower extremity or upper extremity, you get ulceration, you know. That's very important. So this person has an ischemic ulcer, not enough oxygen gets to the toes, and they have pressure point, right? And they develop this ulcer, but it doesn't heal. Initially, when you don't have a wound, you may need just a little bit of oxygen to get by, but once you have this open wound, the oxygen demand increases. And when you don't have that oxygen going to the toe, that's when the toe becomes necrotic gangrene, right? So you could have a dry, stable gangrene or a wet gangrene. This is the gangrene of the finger, right? Smokers, they have small vessel disease. This is a patient with ischemic gangrene of the toes. That's the worst one, actually, if you think about it. When you have small vessels right here, there's nothing you could do to open the vessels. So you end up with the amputation. And then we also see traumatic injuries. Open fractures are always emergency, surgical emergency, so they need to go to the hospital. But once you know, they get discharged, we see a lot of traumatic wounds that need to be followed up with at the wound care center. We manage them till they get better, you know. This is an open fracture where the bone is sticking out, right? And that's how you get an infection. That needs immediate care. This is another one, probably motor vehicle accident, right? You know, the joints disarticulates. And then when you develop open wound, or sometimes a traumatic wound, you can't close the wound, right? Because you got so much blood there, and you got compartment syndrome. You have to drain the blood, and you can't close the wound. So later on, you come in, you use skin graft or skin flap to close the wound, right? And that's what this is. This is another patient with traumatic wounds, open fractures. Questions?
Thank you, doctor.
Thank
If you have any questions, we'd be happy to entertain them.
The bottom line for you, sir, is that you're a type 1 diabetic. The point I think that I hope that you saw here is what doctor was trying to say is that unfortunately diabetic patients have a high risk of having a lot of complications from just a simple little cut on their foot because of what's going on with your diabetes. So what we want you to do is to not do your own self-remedy type things. I would want you to, very first thing is if you get a cut, anytime you go in and see your primary care physician. They need to see that because as doctor is saying, with some of these patients, they had a wound that was a day, 2, 3 days old, and with diabetes, it can get away from you really quick. And then next thing you know, you're ending up with losing a toe or possibly even worse. So when you were younger, you could probably get away with it because your immune system you were right spot on. And now as we get a little bit older, it takes longer to heal. It takes longer to get over those sore muscles and things like that. So especially right now for you, I would highly recommend that you go see your primary care physician, or if it's your feet, definitely your podiatrist. So the hammer toes or the bunions, those seem maybe not that big of a thing, but they can alter everything about your feet. And that's why it's so important to make sure that you have, especially as a diabetic, sir, to have a podiatrist that you go to regularly.
You should not, as a diabetic, you should not trim your own nails. Technically, you should not trim your calluses. You should not use duct tape, any of that. Because if you open up, you're going to have problems, right?
What happens is that somebody will be trimming their toenails, and they go too close, and then it digs down into the skin. It gets red and festered. Next thing you know, you've got a bone infection. The number of people who come into a wound care center that have clipped their toenails and now are losing a toe, it's unbelievable. And or the people with neuropathy who didn't know that they had that pebble, or pins, or paper clips in their shoes, that a wound formed as a result of that because they couldn't feel it. So that's again, you need us to help you so that these things don't happen. And we need to test you and we need to give you, life experiences to help you prevent these type of.
I'll give you an example. I had a patient, he passed away, but he had diabetes, 65 years old, and multiple other conditions, but one of them was diabetes with neuropathy. One time he came in, he was getting really sick with congestive heart failure. So I helped him out, take his shoes off. So as I'm taking the right shoe off, I see a kiwi sticking at his tip of the big toe. And I thought he's joking around with me. So I said, "What is this?" He says, "What is that?" "What is what?" I said, "The kiwi on your toe." You know what happened? He had a kiwi in his hand. His daughter called and said, "I'm at the door, come downstairs." So as he was trying to shovel and get his shoes on, he dropped the kiwi. He didn't know where it went, right? So he let it go. The kiwi was in the shoe, and he's neuropathic. He didn't feel anything. Puts his right foot into the shoe, and it sticks it right in the toe. And he comes in, and as I'm taking the shoe off, the kiwi is sticking out like this. And I'm like, but he didn't have any feeling, right? I would say stay away from, because if they nick you or if they give you fungus, you could be blessed either way. And that's it.